If you've got clinicians, practitioners, physicians, nurse practitioners, PAs, prescribers that you work with that are unwilling to have an educated conversation with you about this, I mean, if they pull out the women's health study, then that means they haven't read any research that has come out in the last 2 years, or actually the last 5. If that's the case and they are unwilling to be your partner in your healthcare journey, it's probably time to find a new partner, right? You can fire them. You absolutely could. But you need somebody that's going to be your partner and help you navigate your health, your independent risk factors, everything that goes into your health and well-being, and what is the right way for you to address this transitional period, whether you're 40 right now, 50, 60, 70, or above. You need a partner in this, not a dictator, and especially not a dictator that can't read. Ladies, are you ready to take control of your menopause journey? Introducing Mastering the Pause, the ultimate ebook that empowers you with the knowledge and tools to navigate this transformative phase with confidence and grace. Packed with expert guidance on hormone replacement, essential lab tests, personalized diet and lifestyle strategies, this book is your secret weapon to combat menopause-related challenges. Discover how to maintain a healthy metabolism, ward off belly fat, and embrace this new chapter of your life. Download your copy now at guide.hormoneshelp.com. That's guide.hormoneshelp.com. And let's make this a smooth and informed menopause transition today. Does hormone replacement cause breast cancer? Or is hormone replacement dangerous for breast cancer? And if so, is it a perimenopausal woman? Is it a menopausal woman? And what does the research really say? So today on Menopause Mastery, I'm going to go into the 5 myths about hormone replacement, and specifically bioidentical hormone replacement, and the so-called risk with breast cancer. So we're going to dig in today, so let's just get going. So if I had $1 for every time I've heard in the last 20 years, I've had somebody come in and actually cry in my office because the doctor told her she was stupid and that she should just accept where she is and that hormone replacement is a dumb idea. And, so we've all heard the gamut. The reason why I'm bringing it up today and I wanted to talk about it is because, number one, there's been an extraordinary amount of recently published research, very large studies, and we're going to talk a little bit about how to read these kind of studies and how to understand them, that really pretty much put a pin in it, right? It can pretty much take and wipe that out. So let's start first with a little bit of a story, right? So the woman I talked to today has started going into the menopausal journey and it experienced what many women experience, sort of this slow onset of symptoms. And the symptoms were becoming debilitating: the brain fog, depression, the anxiety, the insomnia, the interrupted sleep, menopausal sort of belly weight gain. And, the interesting thing is she was very much like me. She didn't have hot flashes or night sweats. And she told me, she said, Betty, I didn't even realize what I was going through was the menopause transition because I thought it was all night sweats and hot flashes. I didn't realize my cognitive issues and all these other things are a sign of menopause, that transition. And just in case anybody's new to my podcast and you haven't listened to it, 100% of women go through menopause. We don't get a pass on that. Guess what? We get to go through it. 87% experience symptoms that are significant. Of the 87%, 78% are unable to get any sort of relief of those symptoms. So here's where it becomes more important, right? And this is why I have created this podcast and I am arming just millions of women with the information. The reason to improve your hormone balance is not just to get rid of night sweats and hot flashes, it's actually to reduce your risk of disease. And we're going to talk about breast cancer today, but there's a lot of research, and I'm going to go over that in the next couple podcast series so you can understand what is really out there. It's not so much that the symptoms are bad. The symptoms are signs of what's going on. And there's over 69. So I did an Instagram clip of 69 different symptoms associated with menopause, and they're all body-wide, right? So the reality is every single system in the body is affected by these hormones, and when they decline, they all start to age more rapidly. And not only are we getting symptoms, but we are actually seeing it in disease risk. So we're going to jump into breast cancer today. And ultimately, why do we have this sort of just groundswell of media hype that took over the nation and took over our medical system in the last 22 years. And if you've never heard me before, I talk about this probably almost every podcast, but just to reiterate it, there was a women's health initiative that was started in 1998 that was halted in 2002 because of a perceived risk for stroke and heart attack in the population. Now, this was the largest women's study ever produced at that time, but there was a lot of bias in how this study was produced. Number one is they intentionally excluded any healthy women. So they were looking with women who already had hypertension, diabetes, metabolic syndrome, so high cholesterol, high triglycerides, weight gain, a combination of symptoms that make you at a higher risk for cardiovascular disease. The average age of the women were 62. And the reason why they did this is they were looking for cardiovascular mortality rate, right? So you want to exclude the women that, this is their reasoning. I sort of get it as a researcher. They go, hey, we're going to exclude people who are super healthy because they're likely to not die in the next, 8 to 10 years while we're doing this study. But these others that already have significant cardiovascular risk, we can maybe determine if there's greater risk, right? Now, the important part is you got to remember something about that. So if the women already had cardiovascular disease risk, which means they already had progressive cardiovascular disease, right? Cardiovascular disease doesn't hit like astronomically fast in a year and you go from perfectly normal to heart disease. It is a decades-long process. So if you're hypertensive, you have high cholesterol, high triglycerides, you've got central adiposity, which is the weight gain around the middle, all of those things are signs you are already developing cardiovascular disease risk. And then obviously there's multiple ways that we can look at it. So they halted the study because, yes, they did find the women had a slightly increased risk of stroke and heart attack. And then as they were going through peer review, which means that the researchers were being checked on their statistical analysis, which is absolutely 100% required because it is absolutely something that can get completely hosed up, right? And I can tell you there are a ton of studies that never get published. And of the studies that do, there are many that have poor methodology, poor conclusions, and should go through better review. So this one, before it was reviewed, it was exposed to the media. And one of the statistics that they quoted was that the women in the study that were on hormone replacement, specifically the estrogen replacement, which is one of your hormones, and synthetic progestins, which are not bioidentical, had a 25% increased risk of breast cancer. Now, you can lie with statistics. So the reality is a 25% increased risk of breast cancer is not statistically meaningful when that went from all women carry a 4 in 1,000 chance of breast cancer if they are menopausal to 5 in 1,000 breast cancer risk, or, pick your poison there. But a 4 to a 5 increase in 1,000 is a 25% increase, but it is not statistically significant at all. It is completely meaningless in the data. So that's what started all of this. And it started this media frenzy, and it started us down this road where we have taken hormones out of women's hands for decades. And up until that point, since the 40s, it was common practice. It was one of the most prescribed medications ever until 2002. Well, so we're going to go through it today, and we're going to talk about these 5 myths, and we're going to talk about how to understand these studies and what to understand and arm you with the information so you don't have to feel so scared. I think that bothers me the most is I talk to these women and they are terrified, right? They're terrified that they're going to do something that increases their risk of breast cancer when not having hormones increases your risk of basically all-cause mortality, whether it's cardiovascular disease, osteoporosis, dementia, stroke, thrombotic risk, colon cancer, lung cancer, and oh, by the way, it actually increases your risk of breast cancer too. And I'm going to talk about what the studies say today. Let's dive in, dig into what the data says, right? So number 1 myth, right? Hormone replacement therapy, including bioidentical hormones, which are hormones that are identical to what our body makes. So think of your hormones as a key, the key that you're taking as a prescriptive agent, identical to the key you made, right? Synthetic forms are like a skeleton key that are almost close to it, but don't work quite the same. You've ever bent a key and you went to put it in the lock and it doesn't really turn, but then you jiggle it and you kind of get it to turn? Think of that as like the difference between bioidentical and synthetic. It kind of works the same, but it's not quite the same, right? So hormone replacement therapy universally increases the risk of breast cancer, right? So I just talked about the study that basically said that. right? So it's the Women's Health Initiative. And get this, on a 18-year follow-up in 2020, and then again in 2024, they found afterwards that there was no increased risk of mortality in any of the women who were on hormone replacement therapy. And they actually, when they redid the statistical analysis, and that was just released 2 months ago, they found that, when that was done again, the mathematical equations and the statistical analysis that they came to was actually incorrect. So now there is no increased risk. So that's number one. When we look at some of the research, there was a study that was done by the Collaborative Group on Hormone Factors in Breast Cancer in 2019. And when they looked at estrogen replacement therapy alone, so replacing estrogen, and estrogen can be given in an oral form, which is a conjugated equine estrogen. So that is made from horse mare urine, so pregnant horses. And it is given orally, and it actually has 13 different estrogens in it. So we make 3, right? So we get 10 estrogens we don't really need, and it goes through the liver first, right? So there's an oral version, and then there's topical. Topical can be done as a patch. It can also be done as a cream or a vaginal insert, and it can also be done as an oil. So when we look at the type of hormone replacement therapy, estrogen, regardless of type, oral, topical, patch, will increase risk of breast cancer. And actually, a recent study showed that there was a 33% decreased risk of breast cancer, decreased risk if you took estrogen monotherapy. And then another one that came out earlier this year was a 16% decreased risk, and that was a Medicare study I'm going to go into a little more detail on in just a second. So monotherapy of estrogen alone has no increased risk. In the Women's Health Initiative and another study, they found that when you took the synthetic progestins, right, which are an oral progestin, there was a slight increased risk of breast cancer in that particular group. And again, synthetic hormones are not bioidentical. They have to pass through the liver, which means they make a bunch of byproducts when they do that, and the body has to handle those, right? So there was a slight increased risk of that. But in the Medicare study, which I'll go into a little more details, they actually showed that if you transition to a topical preparation, like a topical estrogen and a topical progesterone, or a IUD, even better, IUD, or a micronized oral progesterone, which is bioidentical, that risk was completely mitigated. There was no increased risk. So the idea that hormone replacement is going to cause breast cancer in everybody is absolutely not true. Now, one of the best studies that I've seen is the Medicare study. So the Medicare study came out just in the last few months, and it looked at over 10 million women. And so what's some of the things that you have to understand is, number one, it was 10 million women who were all 65 years or older. And they categorized them into 3 different groups. Women that did no hormones ever, women that did hormones and continued to stay on them, and then they also divided that group into the oral conjugated equine estrogen, right, and the synthetic progestins, and then those that did topical, right? So that's second group. And then the third group were women who did hormones, but for a really short period of time, because their doctor would only give them to them long enough to actually, stop the hot flashes. And so they only did them for a few years. And then they checked all-cause mortality, right? So they looked at heart disease, deep vein thrombosis, stroke, heart attack, congestive heart failure. They looked at colon cancer, breast cancer, lung cancer, and several other ways to die. And they found across the board, women that were on hormone replacement lived longer, right? Longer health span. The women who did nothing had a greater rate of mortality across the board. And the women that did hormones for just a short period of time and stopped it lost some of that protection because they never stayed on the hormones. The only group that we saw an increased risk that we would consider important is the group that were taking the oral synthetic progestins, right? The oral synthetic progestins and oral, particularly conjugated estrogen, have an increased risk for blood clot in people with blood clotting risk, particularly if they are postmenopausal, right? So here's what you want to know. You want topical, you want oral bioidentical progesterone doing oral, and you never want to take estrogen by pill because you want to take something topical because it doesn't have to pass through the liver. And then that clotting risk is 100% mitigated. There was another study that just came out a couple weeks ago that showed that clotting risk is mitigated. So if you've been told by your doctor that you have blood clotting risk and you are not a candidate for hormones, then that's incorrect, right? So this Medicare study showed that breast cancer was absolutely not a risk, and it's actually protective against breast cancer, especially in an aging female population. Because, hey, I got to break it to you. Your risk for breast cancer, like if you just leave it alone, is greater as you get older, right? We have a greater risk after our hormones are gone than when we had our hormones, right? So these studies also follow logic. I'm a scientist. I feel like logic should be obvious. And if it's not logical, then I start asking and questioning the basis of the study, because again, usually things that are logical have logical meaning, and we can often find those statistical analysis. So number 2, the duration of use of hormone replacement will increase your risk for breast cancer, right? So obviously, the Medicare study sort of debunked that, right? The increased risk of breast cancer, it was assumed basically from the Women's Health Initiative. And so if we look at a study funded by, they're called Breast Friends, and the Journal of National Cancer Institute concluded that menopausal hormone replacement therapy, vaginal estrogen therapy, is not associated with the risk of breast cancer. And this is even more important, breast cancer reoccurrence or mortality in postmenopausal women treated for early stage estrogen receptor positive breast cancer. So this was a study that was published in 2020. So what this means, if you didn't catch that, is they were looking at women who had already been diagnosed at some point with early stage estrogen receptor positive breast cancer. And what they found is, especially if they were doing vaginal treatment of estrogen therapy, there was no increased risk of breast cancer. No increased risk. Another study that analyzed data from 8,400, a little more than that, Danish postmenopausal women who were diagnosed with early stage breast cancer between 1997 and 2004 showed no increased risk for the reoccurrence who used vaginal and or topical breast cancer risk, so if they were using estrogen. So, and then when they looked a little bit at the subgroup, they revealed an increased risk of reoccurrence in a particular subgroup, and it was only in the subgroup that were receiving aromatase inhibitors. So what that meant is if the women were taking vaginal estrogen therapy, which is often given to preserve the tissues and provide some helpful estrogen in the body, particularly for vaginal atrophy, dryness, urinary tract infections, vaginal health, that in the subgroup that were taking aromatase inhibitors, that'd be like an anastrozole, they had an increased risk. Only the women taking the anastrozole, the most common drug that they give in postmenopausal women for the treatment of breast cancer after chemotherapy and radiation, if they did radiation. So the study's findings suggest that survivors, particularly on tamoxifen, could use vaginal estrogen therapy to alleviate particularly what they call the genital urinary symptoms without increased risk of occurrence, but you don't want to be using those with aromatase inhibitors. The article also suggested that vaginal DHEA might also be a support for those symptoms, particularly vaginally and urinary tract genital support. And DHEA is actually an androgen. It's a precursor to testosterone. So the idea that you've had breast cancer in the past and you can't have any hormone therapy, this would call that into question. So the duration also. So when we look at that Medicare study, again, the women that had been on hormones, they started somewhere along the way. So most of those women that were 65 that started the study and looked at them from, it was 2008 to 2023, I believe was the time span, they were on it for a long time, having not stopped. And they had decreased risk of all-cause mortality, including breast cancer, which shows that you benefit from hormone replacement and you benefit for it when you're using it long-term. Right? And again, that was a 10 million women study. So the idea that you should only use hormone replacement in the shortest amount of time to get rid of vasomotor symptoms, which is hot flashes and night sweats, and that's the only thing you should be worried about, is pretty much kind of dead in the water at this point. Now, myth number 3, and I alluded to this a little bit earlier, all forms of hormone replacement therapy have the same effect, right? Same risk for breast cancer risk. So again, if we look at several studies, the Women's Health Initiative itself found a reduced risk with even oral Premarin had a reduced risk in the monotherapy alone, the women that were only on estrogen. The collaborative group on hormonal factors in breast cancer in 2019 also found that women that were on just plain estrogen only had a lower risk compared to the ones that were on the synthetic progestins. Again, synthetic progestins carry significant clotting risk and other problems because, again, they pass through the liver first and they go through what we call first pass metabolism. And then when you compare never use, discontinue use of hormone replacement therapy, the use of estrogen therapy beyond 65 significantly reduced risk in mortality, particularly to breast cancer. When we look at the Medicare relationship population, it was a 16% decreased risk. 16%. That's huge. When we look at the use of estrogen and synthetic progestins, again, a lot of these studies were using the same ingredients. We have studies with topicals, but they're much smaller. When they used the combination, or when they looked at the combination of oral, there was a slight increased risk. But when you look at the estrogen and non-synthetic progesterone, it wasn't. But again, if we use that transdermal, right? If we use a vaginal estrogen, and which would be considered a transdermal sort of delivery or a vaginal insert delivery, we saw a decreased risk, right? So a significantly reduced risk in breast cancer risk. And guess what? Also endometrial cancer. So part of the reason why we would introduce estrogen and progesterone to women, there's multiple reasons. Progesterone has its protective effects on the body, but particularly in the uterine lining, estrogen's job is to bring blood supply. So if I still have a uterus and I still taking hormones, I need progesterone to counterbalance that estrogen, because that's how our body was designed to function, to have both of those hormones together. So when you look at those, it sort of lets you understand that if you have a uterus, at a minimum, conventional medicine would tell you you need both estrogen and progesterone. Now, functionally, because both of those hormones are protective, because they offer and they confer different support. And I've done many podcasts talking about each one. But again, the data do not support the risk for estrogen and progesterone, particularly topical preparations or vaginal preparations, and the risk for breast cancer. Now, myth number 4. So this is a broader scope now. We start looking out in a broader lens. All women carry the same risk for breast cancer if they're taking HRT, right? So this idea that HRT is risky for everybody and all women carry a similar risk. So here's the reality. There are studies, and really, really strong studies, that indicate that factors like postmenopausal obesity, so if you're overweight, particularly significantly overweight in menopause, you have a greater risk for breast cancer. And if you are premenopausal and you're overweight, you carry a greater risk because our body fat is pro-inflammatory and it produces estrone, not estradiol, which is what our ovaries produce, which is protective. And so being just overweight and particularly obese, which is a BMI over 29, right, we're going to have a greater risk for breast cancer, by far greater than any of the studies that initially tried to say that hormones were risky. Alcohol consumption, the more you drink, the higher your risk for breast cancer. And then you've got other stories or other studies that are even crazier, right? So there's a study that looked at traffic-related pollutants, right? So if you live in a city, the smog. Traffic-related pollutants increase the risk of breast cancer incident. There's actually several studies looking at that. And there's some really good ones, actually, that looked at the different volatile organic chemicals, the CO2 emissions, all these ingredients that are in these greenhouse gases that increase our breast cancer risk, statistically significant amounts, right? So again, you look at that and you go, okay, being in a polluted environment increases my risk. Some of the other ones that I thought were very interesting is also shift work. So night shifts, if you're somebody who works in a hospital or an ER or work overnight, or you're working a variable schedule, you have a greater risk for breast cancer. And a lot of that link is probably because of disrupted circadian rhythms and change melatonin production, which actually has some pretty good research that melatonin can be supportive in an anti-cancer function standpoint, right? So night shift, hair dyes, right? So hair dye use actually has an increased risk, particularly the darker the hair color, right? And of course, nobody knows the clarity around that. Now, anybody that's in the functional community, we would say, okay, that's because there's a ton of toxins in those things and the body has to process that, right? So environmental toxins increase your risk, statistically significant. And if we look at some other, observational studies, there are others that even sort of bring other things into light, right? So I alluded to the night shift work. There's multiple studies that have even found that light exposure to external street lights, right? So if you live in a city and you have exposure to street lamps and things like that, there's actually an increased risk for breast cancer. What is problematic about these, and the reason why I bring that one up is I want to explain what's problematic. Oh, wait, I've got one more. Sleeping with a nightlight. Sleeping with a nightlight on, this is a study done in 2001 by Davis and colleagues, suggests that women who sleep with a nightlight or kept the television on had a higher risk of breast cancer. So why I wanted to bring these up, because it seems kind of nuts. You're like, what? They're not putting people in a hospital and exposing them to light for 20 years and at night and then figuring out they get breast cancer risk. What they're doing is they're looking at that variable, observing through questionnaires what incident of breast cancer people have relative to how much they answer that question, right? Saying yes. Right? Or they're observational studies. And observational studies, epidemiological studies where there's recall involved, or they're just looking at patterns, fail to control for what we call confounding variables. So they fail to control for other things that might also explain results. And so the problem is the media never picks that up. They just sort of run with the headline and go with it. So just because somebody has a greater risk breast cancer based on the study that observed that night shift workers had a greater risk. Is it the night shift itself? Is it disrupted circadian rhythm that the night shift would do? Is it disrupted eating patterns? Because most people, my experience, my husband's been a firefighter for 20 years, they have weird eating patterns because they're not doing what the rest of us do because they're up for 24 hours or they're sleeping in between things, but they're not getting a large stretch of sleep at one time. Is it the lifestyle that goes with it, the extra caffeine intake, the extra, carbohydrate intake and sugar because they feel off, so their body's constantly looking for energy? Those other things that I just mentioned there are called confounding variables that are very hard to control for. So it makes causality could be implied, right? You can imply that there is a plausible opportunity for causality, but it is not a one-to-one relationship. It does not say that it does, but it correlates, right? It correlates. And you have to, as a researcher, your job is to also bring up in the actual study all the possible confounding variables that might be altering your data. Sometimes that is better done than others, but I can tell you right now, it never ends up in the abstract, and it certainly doesn't end up in the media, right? So the observational studies, the idea, so this is myth number 5, that observational studies provide conclusive evidence about a relationship between hormone therapy and breast cancer is completely untrue. And when we look at the most reliable studies, we have all those biases. But when we look at reliable studies, we actually see when they start looking at actual data and controlled data, and that the whole idea that hormone replacement causes breast cancer doesn't really stand up. It doesn't really stand up. So for the women I've talked to, and particularly the woman I talked to today, who said, you know what, I just wanted to cry. My doctor just actually called me out and made me feel like I was stupid. And, and I felt so unheard and so offended by his response because all I was trying to do was be informed, right? Be informed. If you've been in that space, I know I've been in that space, but if you've been in that space where somebody made you feel that way, I hope that this be informed, right? So let me recap what you actually heard here so you can quote just some very basics, right? And then we're going to talk about kind of the way out. What are your next steps if you're like, okay, I feel like I have a better understanding. I'm not as nervous. So let's recap. The idea that hormone replacement causes breast cancer does not have conclusive evidence, and observational studies do not prove that. And when we look at studies like the Medicare study that came out with 10 million women, the Danish study with 8,000, almost 9,000 women, and we look at the studies even looking at women with previous breast cancer and exposure to estrogen therapy, particularly a transdermal or vaginal insert, the data do not support that hormone replacement causes breast cancer. The idea that all forms of hormone replacement have the same effect on the body and or the same risks associated with it is also incorrect. And today we have much more elegant ways to help with hormone replacement that allows delivery for hormones through the skin or through the vaginal tissue straight into the bloodstream. And it doesn't have to pass through the liver, which means that we don't have the liver processing it and then creating stuff after the fact and then get the hormones and all the what they call metabolites, the things the liver produces afterwards. The idea that all women carry the same risk for breast cancer, and all women carry the same risk for breast cancer, particularly on HRT, yes or no, is also a myth. The other things we talked about, alcohol consumption, toxin exposure, obesity, sleep disruption, circadian rhythm, stress, all of those things, hair dye exposure, flight attendants. Did you know flight attendants carry a greater risk, and actually statistically greater risk, than any of the studies that looked at hormone replacement when they were trying to present that hormone replacement was risky? Being an airline attendant actually carries a greater risk. There's multiple studies that have looked at that. And so those things are just observational. They're observational that we see a slight increase in numbers. These people do this for a living, and, could it be the toxin exposure? Could it be canned air? What is it, right? There's solar radiation and other things that you get exposed to on a plane that you don't get as much on the ground. So there's lots of things that confound that interrupt that one-to-one relationship. So the observational studies are not good markers of true risk. They're not definitive. If we could put, a couple hundred women in a study and control all the variables, imagine, not that we would ever do this, it's not ethical, but you take a large group of women, you separate them, and one group's doing hormones, whether it's oral or transdermal, which I would say everything transdermal, and then you control for everything, what they eat, drink, do for the next 30 years, right? That's the only way you can definitively say yes or no. We can't do that because it's not ethical. But we can take the studies that are case-controlled studies, or the large population studies that looked at data, not observational recall data. We can conclude that risk isn't really present. And especially that Medicare study now also brings into question the risk of hormone replacement over time, right? The idea that you do the least amount for the shortest period of time has also been debunked by over 10 million women, right? 10 million women were in that study. And so now we see that hormone replacement is protective. It's protective usually the earlier you actually implement it, but that protection lasts over time. And then that idea that maybe you can't do hormone replacement if you've gone too many years post-menopause is also very much in question at this point. So what is your way out of this conundrum? So I would say, number one, if you've got clinicians, practitioners, physicians, nurse practitioners, PAs, prescribers that you work with that are unwilling to have an educated conversation with you about this. If they pull out the women's health study, then that means they haven't read any research that has come out in the last 2 years, or actually the last 5. But particularly the last few, there's been some very large, profound studies that have come out. If that's the case, and they are unwilling to be your partner in your healthcare journey, it's probably time to find a new partner, right? You can fire them. You absolutely do it. You don't have to stay with them because they delivered your baby or whatever it is. You need somebody that's going to be your partner and help you navigate your health, your independent risk factors, everything that goes into your health and well-being, and what is the right way for you to address this transitional period, whether you're 40 right now, 50, 60, 70, or above. You need a partner in this, not a dictator, and especially not a dictator that can't read. Right? If they're not staying up on the studies, then it defies logic to me to have somebody that says that, I'm here caring for people, but I don't stay up on the research, right? How do we move advancements forward in medicine if people do not stay up on research, right? Now, you can't read everything. I try and read a lot of stuff, and I read a lot of stuff, and I can't keep up on everything. But especially within my area of focus, I try and read all the stuff that comes out because I want to be informed. So number one, if your practitioner isn't your partner, put them to the curb. It's time for them to go. Number two, if you are thinking about hormone replacement, obviously there's a ton of content that I cover on Menopause Mastery, and we talk about it again and again. And you've got options, right? You got options. You can reach out to me on bettymurray.com, and we can set up a conversation for you to talk to a clinician about it. Get informed, right? Get informed, because I know it's scary. I know it's scary because you've been told for 20 years that you're at risk. You want to get informed, right? So take what you learn here. Look up data. If you just put in, recent studies, you can put in Medicare breast cancer or Medicare hormone replacement study and mortality, and you'll see the study. It's available to anybody. I'll include some of the references, a few of the references in the show notes. So if you want to go look up the research, man, I applaud you. Feel free to do that. I want you to be informed. All right. Number three, If you carry some of those risks, so if you are struggling with your weight, because again, if you listen to me, going through menopause increases your risk for weight gain, particularly menopause belly fat weight gain and visceral fat. So that is a greater risk than even considering hormone replacement, much greater. If you consume alcohol, I'm not necessarily a teetotaler, but again, the pervasiveness of drinking daily or drinking a lot or even binge drinking is still very pervasive. And I, joke that it's kind of sport in my age group, but it is. And if you are drinking quite a bit, that carries in itself a significant risk. Obviously, smoking would carry that risk as well, but also protecting your circadian rhythm, getting good sleep, getting dark, right? Helping your body go from bright light in the morning and darkness at night and making sure you get adequate melatonin production also makes a big difference. So we need to be sure of that as well. And we also want to make sure that we're also protecting for toxins, right? So this is your chance to kind of look at, and what I tell people is we just pick an area, right? You'll never get all the toxins out. I had a conversation with somebody the other day. They're like, I'm not eating any seed oils. I'm like, cool. Do you ever eat out? Do you ever eat out? Do you ever get anything packaged? Because you are getting them. You can do what you can. And that's the important part, is we do what we can to get toxins out of our body. So we go, okay, maybe the first thing I'm going to do is I'm going to get rid of plastic food storage, right? I think most of my listeners are probably doing that, but just in case, we don't drink out of plastic water bottles. We don't drink and eat out of food storage, especially food storage that we heat in the oven that's made out, or out in the microwave, that's made out of plastic. We try and reduce our exposure to these microplastics and all these other things because the toxins that are in them absorb in our body and look like hormones, right? We get more natural hair dye if you are somebody that dyes your hair. I don't, but I did when I was younger. I don't anymore. We start to remove our toxins and we just slowly sort of check off the list and we go, okay, I did my food storage this month. Next month, I'm going to get into my cleaning products. Then the next month, maybe I'm going to do my body care products. Then the next month, maybe I do my makeup. You just slowly kind of work your way through and you do the best you can. Because every time I lower a little bit of that other toxin load, I probably lower my risk for all-cause mortality, but particularly breast cancer has a high correlation with toxin exposures, particularly toxins that, I should say, there's correlation. There's enough evidence to say the toxins in our environment are causal for breast cancer risk. And then if you're at that point where you're like, okay, I really feel like I should be on hormones, or maybe I'm doing hormones and I'm not sure I'm doing it right, you've got your resources here at Menopause Mastery. You've got your resources here. You can reach out to my team at bettymurray.com and we can help you sort of navigate that whole idea, right? I have been in this industry for 20 years and it was really when I hit perimenopause at that last tail end that I was like, I'm tired of being screwed. I'm tired of being screwed because I'm female, because of my health history. As women, we have so much more of a complex health history. And because we reproduce, and we're the one that gets to carry the child and go through all of that, we also seem to get the short end of the stick when it comes down to our health. And so that's why I went back to school. It's not because the urge to run up another really large student loan debt. It was because I really felt like I needed to dig into the literature because it just isn't getting out there. And there's still a big gap. There's a gigantic gap, but there's also a lot that just isn't getting exposure. And I really feel like now that we're, the women in my age group, we're here, we're tired of it, and we're mad, and we want to be heard. And we have the right to be heard about our health. And for too long, we've been stuck in this patriarchal environment where our healthcare has been suppressed. Our health itself has been suppressed because of it, and we shouldn't have it anymore. And we shouldn't have to tolerate it anymore. And so that's the hill I'm dying on, right? The hill I'm dying on is women's health and getting the message out. And so that's why I do it. And that's why I want to make sure that you're armed with the information and particularly with the science. I know sometimes I get really sciencey and, maybe not all of it makes sense. But the cool thing is if you can understand the concepts and you got a little bit of the data, then you can go as deep as you want to go. I hope that this was really helpful for you. I hope it helped you overcome some of that worry around hormone replacement and particularly that idea, the myth about breast cancer. It's really not there. And you should feel comfortable in having a legitimate conversation with your provider about how to address your hormonal needs. So thank you for joining me on Menopause Mastery. So if you found this to be a great episode, do me a favor and just hit the subscribe button. It helps us get exposure. We get better guests. It's immensely important to the show. And I appreciate every single one of you because you're why I'm here. Thank you so much for tuning in to the Menopause Mastery Podcast. You are why I'm here, and I am so very grateful. Hit subscribe so you don't miss any wisdom on creating the most exceptional life on our terms. If this episode has helped you in any way, please share it with a friend to spread the love, and together we rise. You can follow me on social media at Betty Murray, PhD, and you can reach me online at bettymurray.com.